Hello, my name is Dr. Stephen Traina. I'm an orthopedic sports medicine specialist with Western Orthopaedics. We're going to talk about anterior cruciate ligament injuries today. The anterior cruciate ligament is the main stabilizer to the knee. It sort of protects the knee from rotatory or pivoting type actions. Once that's torn, the knee tends to buckle or trick out, causing further damage to the knee and accelerating arthritis. Most anterior cruciate ligament injuries occur by a non-contact mechanism. That is, the foot is planted and the athlete pivots, either making a cut in basketball or ski, getting caught and the binding's not releasing, and the knee will shift and tear the ACL. Other types of ACL injuries can occur from a fall or from an athlete such as a football player or a soccer player being struck from the side of the knee. Symptoms of the ACL injury can be trivial or quite dramatic. If it's a high energy type ACL injury, there can be severe pain. The athlete feels the sensation of the knee coming out of the socket and hears a loud pop, has a lot of swelling and stiffness. If it's a low type ACL injury, it can be trivial where they just hear a pop, feel a moment of instability, have minimal swelling and minimal pain. ACL injuries, quite frankly, can be diagnosed by history taking and physical exam 90% of the time. But what I believe is very important when dealing with ACL injuries is to obtain an MRI. The reason for the MRI, not only does it give you conclusive evidence of the ACL being torn, but more importantly shows you the collateral injury that can occur with an ACL injury. Many ACL injuries can have about 40 to 50% chance of a meniscus tear or cartilage injury or other associated ligament injuries. You can also determine how much bone bruising occurred at the time of the ACL injury, and this gives you an idea of how much energy was imparted to the knee at the time of trauma. This is important as far as surgical technique and realistic recovery time and ultimate prognosis of the knee after tearing your ACL. Treatment options for somebody who's not athletic, relatively sedentary lifestyle, and is willing to modify their activities is physical therapy to strengthen the muscles about the knee and an ACL brace, and going through a lifestyle of not doing cutting, pivoting, and high demand type activities with the knee. Most orthopedic surgeons would recommend surgical reconstruction of the knee because most of the people that tear their ACL are active people and want to continue with an active lifestyle and want to decrease the chance of the knee continue to give way and accelerating arthritis to the knee and poor function of the knee in the future. First thing a patient needs to do is see the appropriate physician to have a diagnosis. They need to make a discussion if they're going to proceed with surgery or conservative measures. And the most important thing is to get the knee back in the sense of getting the swelling down, motion back, and getting good quad control. I also find it's very important for the patient to be prepared to do this emotionally. Many of these patients are very depressed because sports are an important part of their life, either professionally or recreationally, and a lot of the emotional depression needs to be overcome before you can proceed with an operation and go in with the right mindset to rehab and to do well. Post-op instructions depend on the severity of the ACL tear and the other collateral injuries to the knee. If there's not significant other injuries to the knee, people are usually on crutches for 1 to 3 days. Weight bearing is tolerated. I do not brace my patients. If there's a meniscal repair or microfracture that needs to be done and other ligaments that need to be reconstructed, it may require a splint or crutches for as long as 3 to 6 weeks. Rehabilitation again depends on the severity of the injury and what was done, but typically most ACLs, after 2 weeks, they come back to the office. We make sure there's no complications. Complications being a big swollen knee, blood clot infection, things that we would be concerned about. We get x-rays, we review the intraoperative picture showing the pathology or the ACL tear and the other injuries, how we fix that, and then we start physical therapy. Physical therapy again is to get the knee working on motion, strengthening, get the swelling down, and then usually by 6 to 8 weeks, most of this can be done in the gym if the patient's motivated and independent, or they can continue with the physical therapy. Again, depending on the severity of the ACL tear, I've had athletes back as early as 4 months to as long as 9 months, depending on other injuries and what their motivation is in the type of sport. Patients can prepare for treatment for an ACL injury by 1, accepting the injury and getting through the emotional depression and upset and anger that they typically feel, because again, these are active people and this is going to change their lifestyle. They need to get the motion back to the knee. We cannot operate on the knee till the knee bends at least 120 degrees. They need to get some quad control and need to get the swelling down. After the knee is ready and emotionally they're ready, that's the time to plan surgery. To learn more about anterior cruciate ligament injuries, I would recommend you click on the Western Orthopaedic website. You can get onto my link that shows you some of the articles and research I've done on anterior cruciate ligament tears to further educate you on this problem.